some about biopsies. And this is another source of anxiety for patients is, they don't know what the biopsy process is. They don't know what the biopsy results mean, and they don't know where the biopsy will lead. So can we maybe go through like a step-by-step, just
Sure.
a kind of a primer on biopsies for patients?
Absolutely. So we do the biopsies at the initial visit if they're interested, and I would say about 95% are, for the exact reason you just mentioned. They want to know, or they might have driven a ways to see me and they don't want to drive again if possible. But largely it's wanting an answer. A thyroid nodule biopsy is done with ultrasound guidance in the office. The exam chair is reclined a bit, so it's like you're laying back. We put a towel down to protect your shirt from ultrasound jelly. It's nice to wear an open shirt just for access. We use the ultrasound to locate the nodule, and then I do inject a local anesthetic onto the thyroid capsule, the muscle, the soft tissue layer, and then all the way up to the skin as we withdraw the needle. The injection, I believe, is typically the hardest part, which is a minor pain, maybe a 2 out of 10 that lasts just a moment. The idea is to inject the needle track so that you don't feel the subsequent biopsies, and many patients don't feel the biopsies. I do get really good reviews on my biopsy technique. Many people who come to me have had their biopsy done at a hospital before by an interventional radiologist. And I would tell you that interventional radiologists are really good at biopsying anything. I mean, lung masses, liver tumors, stuff in bones. I don't know how they do that so well. I just do the thyroid though, and I do it really well. The interventional radiologists have a lot of skills that I don't, but I happen to be really good at thyroid biopsies because it's all I do. So we anesthetize the track so you don't feel the needle go in. We take 4 separate biopsies, 3 if you're not doing so well and you're having a little anxiety and want to stop. Usually all you'll feel is the needle kind of wiggling. I'll agitate the needle to try to pack it full of cells within the nodule. So the needle is hollow and it's got a core, and so we agitate it in and out. I use the capillary technique to draw cells out. And so if anything, people might feel their trachea or their thyroid wiggle a little bit while we do it. 3 aspirates are collected for cytology slides for the pathologist to review and physically look at the cells, and then a 4th is collected for the molecular profiling. We put a Band-Aid on at the end. I tell them they can take the Band-Aid off in 10 minutes. There's usually almost no swelling. An ice pack or a frozen bag of peas conforms really well to the neck if you're having any swelling. Tylenol and ibuprofen are perfectly sufficient for pain, and you shouldn't need more than that. It aches for 2 to 3 days because we do pass through muscle, so you might feel it when you swallow a little bit. But there are no activity restrictions after. You can eat and drink whatever you want, and you can go work out at the gym if you're up for it. I do biopsies on blood thinners all the time. Studies have shown that people on Coumadin, Plavix, Xarelto all do fine, even anticoagulated. So the biopsies, I don't have to have you stop any anticoagulants for that. The results usually come back in 3 to 4 days. The results range from anywhere to a non-diagnostic result, meaning we don't know what it is still, that the nodule was stingy and didn't give enough cells up. It rates that 5% odds of a non-diagnostic result. And they range from non-diagnostic to benign, this gray area in between, and then cancer at the end. If the nodule comes back in the gray area where the pathologist says this biopsy result looks suspicious, I'm not quite sure what it is, it doesn't look benign, it doesn't necessarily look cancerous, then depending on how they term it, they use the Bethesda scoring system, which is a normalized and validated profile. Then depending on how they term it, we use the molecular profile next. And the molecular profile is where we test that sample for all these tumor marker genes and proteins to try to be a tie-breaking vote and say, yes, this is cancerous and it needs to come out, or no, it's not cancerous and you can leave it alone. That's the value of that molecular test that we have now that we didn't have 10 years ago. 10 years ago, if you had an intermediate result, it was surgery for you, and we'll just hope and find out that everything's okay. And now so many patients were able to avoid surgery with molecular profiling. The molecular tests take about 2 more weeks to get the results back because they're not run until the first biopsy is done. Insurance covers a large portion of those, a very large portion, and then most of the ones that aren't are paid for on like a prorated scale base, so it's not gonna be thousands of dollars. So we collect the sample and just store it in case we need it. And then I tell patients too that even when we're ordering that molecular test and we're waiting 2 more weeks, the odds are still heavily in their favor that they're non-cancerous. So when the biopsy shows atypia of undetermined significance, that's still only a 15% chance that this thyroid nodule is cancer and an 85% chance that it's not. I tell folks, yes, it's 2 more weeks, but rest easy. these are odds that we like still. And so we wait for the biopsy results on that.
Which of those biopsy results would then make a person a candidate for thyroid RFA?
So Bethesda 2 is benign. That means they found enough features and enough cells that they feel very comfortable saying that this is a non-cancerous result. Non-diagnostic results you'd want to repeat and ideally get a benign result. The results should always be interpreted, in my mind, also in light of the ultrasound appearance of the nodule. Some nodules, as Dr. Tufano pointed out, obviously look like cancer, and for whatever reason, you've got a benign result. And you have to take all that into consideration and say, in this particular uncommon case, I feel very uncomfortable leaving this nodule in place. But I would say that over the last, even just 2 or 3 years, I've only had 1 or 2 nodules where I really did not trust the biopsy results.
Really?
So it's quite common to trust your results. So another portion of what I'll tell people is that a benign finding is 97% accurate. So it means there's only a 3% chance that the pathologist is incorrect. And that is really about as good as it gets in medicine. That's really accurate. So when the biopsy says it's benign, we can really trust that a lot, and we can lean on that. And then we can sometimes do a second biopsy if the nodule's enlarging over the next couple of years or so. Even with a benign result, I typically do schedule my own follow-up ultrasound in a year just to make sure that the nodule hasn't grown dramatically or changed. Industry-wide, that has proven to be a safe way to monitor nodules, to rule out this small chance of a false negative biopsy, meaning that your biopsy was benign, but actually it's cancerous and we just don't know it yet. And the way they found that is they took a number of patients, I forget the study, probably between 1,000 and 2,000 patients who ultimately had surgery, and they just looked back and said, was it cancerous or not? And they only found a cancer in 3% of those.
What about thyroid cysts?
Thyroid cysts are almost uniformly benign. Even in the American College of Radiology guidelines, typically pure cysts don't require any further follow-up. They're also not very amenable to tissue sampling because tissue sampling requires some cells, and you need a solid tumor to really collect cells. Cysts are full of fluid, which means nothing to a pathologist, nothing. So in order to get any tissue for them to say, I see what's going on, you have to have a solid component of that cyst or a mixed nodule. But a purely cystic lesion is not cancerous in almost any setting.